talk about the conservative management of severe preeclampsia. Next slide. The potential benefit for conservative management of severe preeclampsia is that we may get another week to 10 days out of the gestation. And if we can advance gestational age, then there's less days in the NICU and less fetal complications. And so included in those complications are respiratory distress and necrotizing enterocolitis. Now, there has been 2 randomized trials with very small numbers that have shown this. Next slide. So the first question is there a gestational age at which we should not do conservative management? And obviously after 34 weeks, we shouldn't continue. But on the lower end, we shouldn't consider conservative management in pre-viable pregnancies. So the reason this is the case is that most of these babies are growth restricted severely. And even if you can get them to past 23 weeks, often they don't live. So this is a combination of different studies. In less than 23 weeks is no one survived. 23 to 23 and 6, 18% survived. And after 24, 58% survived. Next slide. So when a patient presents between 23 and 34 weeks with preeclampsia, the very first thing we should do is a maternal evaluation. With vital signs, we should make sure her urine output's good. We should look at her symptoms, ask specific questions about her headache, blurred vision, shortness of breath, chest pain. And we should also ask about contractions, abdominal pain, or bleeding, because it is a potential severe preeclampsia has a potential of causing an abruption. The labs that are necessary is a CBC with platelets, LFTs, and a serum creatinine. Next slide. In addition to the maternal evaluation, we should look at the fetus. That we should put the baby on the monitor along with the contraction monitor, and the estimated fetal weight as well as the amniotic fluid index should be looked at, because it's not uncommon when you're seeing really early severe preeclamptics for there to be estimated fetal weight less than 500 grams and in oligohydramnios. If the baby is growth restricted, you should then do Dopplers to see if there's absent or reversed end diastolic flow. Next slide, please. So when a patient comes in, your initial management should be on labor and delivery, because they will need more intensive monitoring than they usually do on the floor. And so we give steroids. We give them magnesium, usually for 24 hours, but we sometimes continue at 48 if we're trying to get steroids on board and we're worried about the patient's season. We also give antihypertensive medication. Initially, we give IV medication, and then we start oral medication if we're going to conservatively manage them. And obviously, we do the maternal fetal evaluation that I just spoke about. Next paragraph. So there are a few complications that are really contraindications to expected management. One is eclampsia, 2 is pulmonary edema, 3 is DIC, 4 is uncontrollable severe hypertension, 5 is abnormal fetal testing, 6 is abruptio placenta, and obviously if the baby is dead, there's no need to conservatively manage these. Now, one word of caution, and Barry can say how he treats this, but pulmonary edema to me is due to the disease and not due to the magnesium, okay? And I have come in so many mornings and people got Lasix overnight because they had had MAG 3 or 4 days ago and they're just in pulmonary edema from MAG. Even if I got them on magnesium, I really think if they go into pulmonary edema, it's their disease and not the magnesium. Next slide. So there's some people we deliver after corticosteroids, obviously if they're 34 weeks. If they have persistent symptoms like a headache or blurred vision or, right upper quadrant pain if they don't have elevated liver enzymes. If they develop HELP, severe oligohydramnias, reversed end-diastolic flow, labor or prom, or significant renal dysfunction. Now I skipped one and it's fetal growth restriction less than the 5th percentile. If I have fetal growth restriction and decent Dopplers, I will continue to manage them like a growth restricted baby and follow the Dopplers, and when they get abnormal, then deliver the baby, okay? The other thing I want to say about the renal dysfunction, when we see diabetics that's already got a creatinine of 2, or we see adult polycystic kidney disease and their creatinine's already elevated some, those individuals actually need every nephron they can save to prevent dialysis and ultimately a kidney transplant. So I am very conservative with people with significant renal dysfunction, and that is a trigger for me to deliver them in the 48 hours after the steroids. If they just got a renal function of 0.9 or 1.0, and this is all related to preeclampsia, I may still conservatively manage them. Next slide. So with expectant management, you need to make sure you have adequate maternal and neonatal resources. I actually recommend that you have a maternal fetal medicine in your hospital. Um, and it's not that, well, when I say maternal fetal medicine, I meant residents in maternal fetal medicine in your hospital. And the reason I say that is these patients may abrupt in the middle of the night, and you need somebody that will go and see them and evaluate them, okay? Because if they start having a little bit of vaginal bleeding or their strips a little bit different, you need to look at that patient and you need to look at the monitor and you need to assess her again. Now, expected management is inpatient only. And, I have a lot of Donna-isms. And one of my Donna-isms, and I've heard this in a meeting from Sabai and Jim Roberts, is there's no such thing as mild preeclampsia less than 32 weeks. And so all of these should be inpatient only. And if a patient, if a patient with like chronic hypertension settles out and does fine, I might send that patient home. But if this is a person with no no other disease, and this is their first episode of, hypertension, then I primarily prefer inpatient management. We obviously stop the magnesium. We don't keep patients on magnesium over 24 to 48 hours. We monitor their vital signs, symptoms, at least every 8 hours. And if you read the hypertensive guide, it'll say that you should do lab monitoring your CBC, LFTs, and creatinine every day. And then as the patient stabilizes, every other day. But some of our patients stay in the hospital a long time. And the last thing I want to do is use all their veins and have to go and put in a long line. So, yes, I follow their labs frequently in the beginning, and then I might space them out to Monday and Thursday. Now, I don't space things out if I'm worried about something, like the platelets are 120,000, and I'm worried they might be 60,000 tomorrow. I look at the labs that I'm monitoring, and it depends on the abnormalities as to how much I will space them out. Now, oral hypertensives, antihypertensive drugs, they help prevent hypertensive emergencies in the mother, okay? But it doesn't delay the onset of preeclampsia. It doesn't help the babies grow. It doesn't prevent the complications of preeclampsia. So you have to remember, this is only for hypertensive crisis for mothers. Next. So this is one of the largest, the largest area for potential trouble is you got somebody in the hospital, they've been doing great for 7 days, and you've maxed out on, say, less procardia, and then on the 8th day, they start the blood pressure start coming back, they start worsening, and you decide to add labetalol. And then you work to escalate 2 or 3, 4 days, the labetalol, and you're intermittently giving her IV drugs to bring down her blood pressure, that patient needs to be delivered. I mean, she is definitely worsening. She is definitely, her lab, her clinical situation's worsening, and so she needs to be delivered. Significantly worsening maternal labs, abnormal fetal heart rate testing, and I can tell you, if somebody's early and they have abnormal testing, not a category 3, they need to be delivered. But if they have a biophysical profile that I get 2 6s on in 12 or 24 hours, that baby is being delivered, okay? I actually try to teach that the day I admit a patient, I decide, when I've seen her whole clinical situation, when I am going to abandon expected management, okay? Like some patients, I will say I will max out one drug, and then when they get unstable, we'll deliver it. Sometimes I max out on 2 drugs, especially the women that are 24, 25 weeks, because, a few days or a week means a huge difference to those people, okay? If I'm 32 weeks and my creatinine's rising to 1.2, I'm going to bail, whereas at 24 weeks, if they've got some worsening, don't have underlying disease, I might wait until it bumped again to like 1.4. And then, like I said, the abnormal fetal testing, have a low threshold for this, because you always have to worry about an abruption. Next slide. Now, often we ask about the mode of delivery, and if a patient is less than 28 weeks, especially if they have IUGR and abnormal Dopplers, the incidence of C-section is 93 to 94%. The only patients that I usually labor in these instances are people that are laboring on their own, or they've ruptured membranes or laboring. Above 32 weeks, I almost always induce those individuals, because their chances of a vaginal delivery is 60 to 70%. Now, in between 28 and 32 weeks, most of the time I will induce these people, and if they require a C-section, it's usually the baby doesn't tolerate labor. So if I start out of the chute with the baby that's growth restricted with abnormal Dopplers like absent end diastolic flow or reversed end diastolic flow, I'm going to take that patient to a C-section. Whereas if they're 30 weeks and they have normal Dopplers, normal growth, I feel like I can induce that patient. The other thing is, if a patient is getting really sick when I'm inducing them, right in front of my eyes, their platelets are dropping, their liver enzymes are getting worse, then I am going to bail on a vaginal delivery or a trial of vaginal delivery, and I'm going to go to the C-section route. And that is the end of my, try and make sure, that was the end of my talk.
Thank you so much, Dr. Donna Johnson. And before we go to questions and discussion, especially since folks have just been logging on. I want to make everyone aware that you can request the video presentation of the slide sets. And in order to do that, you need to email me at greater@musc.edu, which you see on the screen. If you are calling in, I'm the person who sends you the invite, so you can simply grab my email off of that. In a moment, I am going to post our new website address in the chat so that you can access that. Our PowerPoint slides are always there, but as you see, listening to the video is quite a different experience on listening to it live. I will go ahead and turn it over to Dr. Campbell again now to facilitate. Thank you.
Thanks for joining us, everybody. That was great, Donna.